Hi everyone, and welcome to our presentation on exploring the quality paradigms in integrated care, the need for emergence and reflection. My name is Wilma van der Vlegel. I'm a lecturer at the University of Applied Sciences in Utrecht in the Netherlands, and I'm working on the master's program of integrated care design. And today I'm presenting with my colleague Everard van Kemenade, who will introduce himself and give you a theoretical background on the four quality paradigms. We explored the four quality paradigms in the articles of the International Journal of Integrated Care over the past 5 years. And after the theoretical background, I will give you the results on our research. We would also like to acknowledge the contribution of Marjolein van der Vlegel, who is a researcher at the Erasmus Medical Center in Rotterdam. After our presentation, we can discuss any questions, and during the presentation, keep your own research in mind, your own care program, or perhaps even your own care as a patient, and we can see if you can recognize the paradigm you're using or you're in.
Ladies and gentlemen, people also within the integrated care community have different lenses through which they see the world. My name is Everard van Kemenade. I took my PhD at Erasmus University in Rotterdam on quality management. And I say so because the theoretical background that we used in our research comes from quality management. More specifically, the last 10 years there was a discussion within the Dutch quality movement on what they called the paradigms of quality. And I was heavily involved in that discussion. And finally, we came out with 4 quality paradigms that you could say emerge from the interaction between the experts. These 4 paradigms are the empirical paradigm, the reference paradigm, the reflective paradigm, and the emergence paradigm. And we used these to look at the articles of the International Journal of Integrated Care for the last 5 years, and that's why I'd like to go a little bit deeper into these 4 paradigms so that you can use them to understand our research, but maybe also to judge your own research. The empirical paradigm. The empirical paradigm considers quality to be conformance to requirements, like the quality expert Crosby said. The focus is on control, focus is on measurement. And the scientific philosophy here is positivism, as you can imagine. An example is that most of the systematic literature reviews belong to the empirical paradigm, as you can see. The second paradigm, the reference paradigm, in that paradigm, the definition of quality would be fitness for use, like another quality guru, Duran, always said. It is fitness for use because the focus of the reference paradigm is continuous improvement to make things, for instance, care, to make care better for the patients, so continuous improvement. The scientific philosophy of the reference paradigm is constructivism or interpretivism. An example here could be an article on the development of pathways or protocols for integrated care. The third quality paradigm is called the reflective paradigm, and in the reflective paradigm, quality is considered to be an event, like Robert Pirsig said. And the focus of this paradigm is on the professional, on discussions between professionals also on what quality at a certain moment of time in a certain place is. And the scientific philosophy that belongs to the reflective paradigm is subjectivism, as you can imagine. And examples of this are, for instance, most editorials and perspective articles within scientific magazines. And the last and also latest quality paradigm is the emergence paradigm. And in the emergence paradigm, quality is dynamic. Quality is unpredictable. The focus is on uncertainty, coping with uncertainties of these modern times. It is on embracing even the uncertainties and trying to find, in co-creation with all stakeholders, solutions for all the problems that we have. And the scientific way of thinking here is the pragmatism, but you can also see participatory research, you can see action research, and it's often based on the complexity theory. An example here could be the co-creation of a network for elderly in a specific region. It's important to see that these four lenses are all needed. That is to say, none is better than the other. Which is the most fit for a specific time and a specific place depends on the context. And we have to understand, sometimes combine, sometimes switch between all these four paradigms. And that is called epistemic fluency. What we need here is epistemic fluency. Now, with these four paradigms, we looked at the articles within the International Journal for Integrated Care of the last 5 years. But important to see is that what we do know about the contexts is that in a planned and ordered and certain context, the empirical paradigm and the reference paradigm fit best, where in an unplanned, uncertain, unordered context, the reflective paradigm and the emergence paradigm fit better. So, when we looked at the articles within the International Journal, we found that it's important to look at the aims of the articles and more or less also at the values that the articles expressed. So what we did is to look within the paradigms what the aims and values are. You see on the next slide that the aim of the empirical paradigm is explanation, the prediction. And the values that belong to this paradigm are accountability and accuracy. In the reference paradigm, the aim is to understand and reconstruct, and the values here are success and improvement. In the reflective paradigm, the aim is critique or support transformation, and the values are professionalism and wisdom. And in the emergence paradigm, the aim is interaction between these stakeholders and co-creation with them. And in the what about the values? It's about flexibility, and it's about willingness to change. And so we looked at the articles within International Journal of Integrated Care, and my colleague will explain what the results of that research and discuss with you the results in the next part of this presentation.
So based on these characteristics, we reviewed 255 articles of the International Journal of Integrated Care. And based on the aim of this study, we placed them in one of the four quality paradigms. And these articles were from 2014 until 2019. And as you can see, the reference paradigm is dominant with 58% of the studies, followed by the empirical paradigm with 21%. As the empirical and reference paradigm fit best in contexts that are stable, this means that as researchers we choose for these paradigms, and perhaps we can discuss this because as we all know, integrated care is complex and complexity is often mentioned, and the collaboration between health and social services and the context we consider also complex. So this raises the question why only 21% of the studies were placed in the reflective and emergence paradigm, which fit best in unstable context. For every article, we also determined the domain of impact in practice, policy, and research. And the domain of practice was mainly influenced by the reference paradigm, as well as the domain of policy. The domain of policy was also influenced with 35% with articles that we place in the reflective paradigm. This is good to know because if you want to change policies, you might need the reflective paradigm. The domain of impact on research was mainly influenced by the empirical paradigm, and this could be expected. As an integrated care, we value a person-centered or personalized approach. We determined for every article if the patient had a role in the study, and this role could be a consultative role, a collaborative role, or even a leading role. In 20% of the studies, the patient had a role. When we look at the emergence paradigm, although there are not so many articles yet, but the emergence paradigm, in the emergence paradigm, the patient had a role in 37.5% of the studies. Perhaps you would like some facts and figures on the continent you come from. So we're going to show you some results on the different paradigms for your continent, and I'm going to highlight just a couple of numbers. When we look at Europe, we can see that in the emergence paradigm, we found 3 articles of the total of 165 articles in Europe over the past 5 years. And the emergence paradigm only consists of 1.9% of the articles in Europe. When we look at the 2 paradigms that we place in unstable contexts, and we look at Oceania, these 2 paradigms consist of 25% of the articles. When we look at North and South America, and we look at the 2 paradigms that we place in stable context, the empirical and reference paradigm consists of 85% of the articles. Asia, who is just starting to contribute to the journal and has 18 articles over the past 5 years, has 2 articles we placed in the emergence paradigm, which for this continent is 11%. When we look at collaborations of continents, it's noteworthy that 36% of the articles we placed in the reflective paradigm. So perhaps collaboration encourages reflection. We can see and we can discuss that our research approaches are not consistent with the complex environment and conditions we encounter. And perhaps we can discuss which values we do embrace in integrated care and in our research. So we conclude that the reference and empirical paradigm are dominant in integrated care research, and that the outcomes do not reflect the complexity in integrated care, the awareness of the context, and the patient-centered role that we would have expected. We think that more awareness of the used research philosophies is needed, and that researchers should clearly state their aim of the study, and that the patient should have a more central role. So If we look at the road ahead, and perhaps if we strive for a scientific integrated care paradigm, the current challenge for integrated care is not about preventing chaos to occur by planning, checking, and making the right choices for adjustment, but it is about perceiving and embracing the uncertainties and the chaos and seek for synergy with other organizations and people.